In the DISCUS trial, the design was 1-to-1. Patients were randomized to receive a standard 6 cycles of platinum-based chemotherapy. According to the investigator decision, they could go for gem-carbo or gem-cis before offering Avelumab maintenance for up to 2 years, versus the experimental arm diminishing the number of cycles, only 3 cycles of platinum-based chemotherapy before starting Avelumab maintenance. Patients were stratified according to 2 factors. The first one, liver metastasis, yes or no. Second one, the choice of platinum-based chemotherapy, cisplatin or carboplatin. The primary endpoint is important here because that was patient focus and it was the quality of life of the patient in between the baseline versus the completion of cycle 6 in the standard arm, 6 cycles, or the equivalent time point in the 3 cycles arm. The primary outcomes that we have is that we met the primary endpoint. So our patients at DISCUS demonstrated that the quality of life was better when offering only 3 cycles of platinum-based chemotherapy instead of the standard 6 cycles of platinum-based chemotherapy. In terms of the quality of life, we saw that the differences in the quality of life were early separated, the curves. So as soon as the patient stopped the chemotherapy in the 3 cycles arm, the quality of life improved, and that improvement was maintained over time. I think this is relevant and important. In addition, what happened with the efficacy? Because we tried that by squeezing the chemotherapy, we were impacting in more responses, deeper responses, and longer responses, translated into better survival. That was not seen at the DISCUS prospective randomized trial. Very similar number of responses. 61% of patients responded in the 3 cycles only arm versus 59% in the 6 cycles arm. And interestingly, less patients progress as primary, as first response or best response in the 3 cycles arm only, 6% versus 10% in the 6 cycles arm. Progression-free survival and overall survival Kaplan-Meier curves largely overlaps, with a median overall survival in the 2 groups of 18.9 months, exactly the same, and the hazard ratio was 1.15 for overall survival. We cannot claim for non-inferiority because of the limitations of the statistics and the design of the trial, but I think clinically speaking, I think we can say that there is no clear detrimental activity by diminishing the number of cycles.